Our next speaker is Dr. Palmer. He is a radiation oncologist specializing in treatment and central nervous system, or CNS, malignancy, such as primary and secondary brain tumors, as well as cancers of the spine. He is also the pediatric and malignancy disease site leader and a committed physician scientist, devoting a significant portion of his professional time to prospective clinical trials and strategy to improve efficiency in radiation. I'm glad you're doing this. I have no idea what you're doing there. Okay, let me finish introducing him. I know. Yep, he has published over 200 manuscript book chapters and abstracts, including publications such leading medical journals at NEJM, Cancer Cell, Lancet Oncology, JAMA Oncology, and Natural Medicine. His research focused on transitional oncology, biomarker discovery, and the interaction on diet on cancer therapy. He served as a national co-PI on 3 brain metastasis trials in the NRG Oncology. I might have to text them. And Alliances for Clinical Trials Group, as well as the several studies through Children Oncology Group.
We fixed them all. So thanks everybody for coming in and seeing sort of the latest updates that we have for melanoma patients. I'm the sort of CNS and pediatric radiation oncology director. We'll go over how radiation treatments can affect patients with brain disease. These are my disclosures. So try to understand how brain tumors as well as radiation treatments will affect patients' cognition, which I think is the most important aspect of a patient's functionality with brain disease and how radiation impacts that. And so I think over the years, we've gotten very complex in how we treat brain diseases. Historically, and kind of in some of the earlier talks, you've seen that it's sort of broken down into 3 main categories of medical therapy, surgery, and radiation treatments. And historically, radiation was just thought of as being sort of a targeted radiosurgery or a whole brain radiation therapy. But you can see we sort of put together an international panel and started to decide how do we break down, how best do we break down how to use each of our radiation tools. And you can see how it becomes very complex, how we think about different options based on a patient's overall comorbidities, their functionality, their symptoms, the size of the tumors or burden of the tumors in the brain, and what parts of the brains that it's affecting. And so we have various versions of whole brain radiation therapy, targeted therapies, radiosurgeries, and now using proton therapy for various reasons for tumors involving the brain. As a radiation oncologist, we understand that there are no studies, and especially no randomized studies, that demonstrate a survival benefit to the addition of radiation treatment to the brain. So we have shifted the majority of our focus on how can we best balance tumor control in a patient's functionality and cognitive status and their quality of life. Because those things are sort of the most important things to weigh as we try to understand how to impact a patient that has a tumor in their brain. Of the 6 trials that have most recently come out over the last 20 years, we've essentially seen that the less brain treated, typically those patients have better cognition, and that's what we see here. And we need to sort of understand how each of these therapies and the patient's personal status impacts the overall ability for that patient to function. So we think of it as a seed and soil model. The soil is those host-related factors. What is the patient bringing to the table that impacts their overall cognition? There's nutrition, there's cognitive reserve, age, immune reactivity, genetic factors, and we've seen this in our whole brain trials. There are genetic factors that are tied to dementia that can make these patients more susceptible to cognitive decline with radiation therapy. Seed refers to those things that the tumor is bringing. So the tumor genetics, the mutations, the cytokines that it's secreting, or paraneoplastic disorders can all impact cognitive ability. In the pesticides, we think of as what are we doing to the patients that can potentially affect their cognitive status. That's chemotherapies, targeted therapies, and various radiation treatments, as well as sort of how we impact them with surgery. And so it's multiple contributing factors that all impact the patient's cognitive function. So it's not one thing. We know we study these various areas and try to determine if radiation is the cause, but there are actually many causes of a patient's cognitive decline over time, both with age, but also with their treatments. In aspects of cognitive function, how we think of the various ways a patient's cognitive function is impacting their daily life, we break down into various subcategories of different versions of visual working and episodic memory, attention, concentration, reaction time, and motor speed, as well as processing and executive functioning. We think of those as the most important and testable things for us. The most used cognitive function tests that we have in our clinical trials are the Hopkins Verbal Learning, the Controlled Oral Word Association Test, or the COWAT, and the Trail Making Test. Those are all testing verbal memory, delayed recall, fluency, and executive functioning. Those are the ones that that I'll kind of highlight a number of our clinical trials, but these are the ones that we use to try to understand, are we impacting and positively impacting a patient's cognitive status? So in the largest intact brain metastasis study that changed the practice of care for us years ago was the Alliance clinical trial 0574. This was for patients that had 1 to 3 brain metastasis, all not needing surgery, primarily looking at cognitive deterioration. So that's a patient's survival without declining cognition in 1 standard deviation below their baseline in 6 cognitive tests. And the 6 cognitive tests are the ones I just mentioned. And what you can see is that whole brain radiation therapy up to this point was the standard of care. Everyone would get routine whole brain radiation therapy in the 90s and 2000s. And what we found was targeted radiosurgery for these patients had a significant improvement in cognition. But I'd still highlight that 2/3 of these patients are still having cognitive decline by this definition. I'll kind of talk to you why this is a useful definition, but not sort of is truly meaningful to the patient definition, because typically a 1 standard deviation decline may not be noticeable, but is testable. What we found in a similar design study called N107C, this was the surgical version of that same trial. So it's 1 to 3 brain lesions getting radiosurgery or whole brain radiation therapy, but one of them had to be large enough to require surgery. And what we found was essentially the same outcome, that if you give radiosurgery, those patients have a better overall cognitive ability, and overall survival was not impacted. These patients did have better entire brain control with whole brain radiation therapy, and at least in the initial analysis had better surgical control with whole brain radiation therapy, but worse quality of life and cognition. So we've transitioned our practice to being radiosurgery for these patients. Interestingly, because of this decrease in control of the resection bed, both in this trial and others, including an MD Anderson clinical trial run by Anita Mahajan, we've demonstrated in historical controls that fractionating the radiation treatment or doing it over multiple days as opposed to 1 day does have an increased control. So with Paul and I and others ran a clinical trial that is closed 2 years ago called A07-1801, which was a randomization of 1 treatment versus multiple for postoperative patients. So because the historical standard was to remove a large tumor if it's causing symptoms. And so we randomized patients to a single treatment or multiple treatments to try to decide if this would actually impact the control to improve these patients' control longer, because these patients, as opposed to N107C, are likely living years. Only about 1/3 of patients lived over a year in the original studies. And so going back to kind of trying to understand how can we impact cognition, we looked at the long-term impact, because what we miss in a lot of our Alliance and NRG trials is the long-term impact of our treatments. We look at the 3-month impact of our treatments. And like I mentioned, we looked at the single standard deviation drop in their cognitive scores, which, insurance carriers, patients ask us all the time, is that really meaningful to have a 1 standard deviation drop that may be not permanent? And I would argue it probably isn't, because the majority of those patients don't notice that they have a cognitive drop, although they may be slightly slower in the COWAT or the trail making test. We wanted to define how are patients impacted a year post-treatment in these long-term survivors. And the purpose of this is mostly because we think that there are more long-term survivors now than there were 10 years ago. And this will continue to be the case as systemic therapies improve. over the next 10 years. And so we need to understand how can we improve the cognitive ability of our patients so that we can control tumor, but not impact them years after treatment. And I would argue the late effects of our initial treatments are much more important as opposed to the transient several month impact that tend to go away. And so we looked at the N107C study, which was the surgical cohort that I mentioned. And what we found was if you start to now narrow down this patient population into more than one standard deviation drop, which is what was reported in the original trial, into more than one standard deviation, so 2 and 3 standard deviations, and I would argue 3 standard deviation drop in from their baseline is a significant drop. These patients are really suffering in those areas of executive functioning and memory. And then we also broke it down into 1, 2, or more, or 3 cognitive measures. So basically saying if you impact, say, verbal memory and executive function and processing speed, how does that impact quality of life? Because now we're broadly injuring that patient's ability to have memory versus maybe just slowing them down, which tends to happen as we get older in general. And so we did look at this, and then we found, as you can see highlighted sort of in the red, is that whole brain radiation therapy across the board not only impacted, which was the primary endpoint of the clinical trial, which was 1 standard deviation, it impacts patients in multiple cognitive domains and significantly more than 2 and 3 standard deviations. So we do see this, and it significantly impacts our patients. We also wanted to, and this is sort of the first time we were able to actually associate significant decline in cognition with quality of life, which is how we were able to get it into JAMA, is that if you look at cognitive decline and quality of life, it not only impacts overall quality of life to have a diminishment in 2 standard deviations, but it impacts their functional well-being and their emotional well-being by up to about 8 to 10 points, which is sort of what we would consider a significant drop. Also highlighting here that we're not only impacting patients early on, but these patients, especially in the whole brain arm, that right-sided figure, these patients, once they're impacted, tend to be impacted permanently. So like once they're injured, their injury seems to persist. We're also looking at publishing now the combination of those 2 trials that I mentioned, so the intact and the post-operative cohorts of the Alliance trials, pooling those patients that are now living over a year. And what we see is that on the right, the general things that we want you to get across is that majority of those curves are trending downward. And so trending downward means that from the start of their radiation treatment up through 1 year, and here's listed up through 2 years, these patients are having a decline in each of these domains. In both patient cohorts, the COWAT does improve with time, which is interesting. But I would also highlight that the curves, the slopes of the curves are also important, that their steepness is how severely they're impacted and how much they're impacted over time. And it's a much steeper decline in the whole brain radiation arm than the radiosurgery arms. And you can see that even with some of the radiosurgery, you can be negatively impacted. So the trail making B, for instance, in the radiosurgery starts out quite low, but you can see after 2 years, they're getting back towards their baseline. We also looked at similarly from our sort of JAMA paper that we looked at the 1, 2, and 3 standard deviation drops in this cohort. And you can see that even more serious, the 3 standard deviation decline in these cognitive measures is much worse with the whole brain radiation arm. And then now that we have more patients, you can see here that there's quite a few patients on the whole brain radiation arm that are impacted by more than 2 standard deviation drop than the radiosurgery patients. And then similarly, we're seeing a functional well-being and an overall quality of life diminishment. And so how do we improve this? There are multiple medications, and I know we mentioned some of the vitamins. There are multiple sort of things that we want to use as adjuncts that can potentially improve cognitive ability. We know that there are studies currently ongoing through the NRG and others looking at sort of brain training programs, biofeedback, cognitive behavioral groups, psychoeducation, and relaxation, physical exercise. Each of these things can sometimes impact these domains, but not always. One of the ones that we used in a clinical trial about 10 years ago was memantine, which was originally a drug used for dementia, but we use it in radiation treatment to decrease the loss of sort of what we think is like the stem cell niche of the hippocampus. And when we looked at this trial, it's overall a negative trial. And then historically, that's because 10 years ago, these patients very rarely lived more than 3 months. And this endpoint was at 6 months. And so we had very few patients survive to 6 months. But if you look at the subgroup of patients that actually lived long enough to make it through the cognitive testing, there was a significant improvement with the addition of amantine for their memory. So it's made it into the standard of care as a radiation oncologist. We also now have a clinical trial published in the JCO that demonstrated that if you spare a memory center called the hippocampus, which is a very radiation sensitive area of the body, by essentially carving it out with our radiation, which is something that we can do now with IMRT, you have an additional improvement in their cognitive ability. So this is the current standard option that we give patients. The MD Anderson group has also not yet published, but presented multiple times that for patients with more than 3 metastases, because currently we don't have randomized evidence that supports that we can use radiosurgery for high number of brain lesions, that this also positively impacts their cognition. So similar to our low number brain met volume, that if you have many more brain lesions, which happens not often for our melanoma patients, that radiosurgery still can offer them benefit to their cognitive ability. We have an ongoing trial in the Alliance and the Canadian groups looking at any number of brain metastasis, initially designed as 5 to 15, similar to the MD Anderson trial, but now is uncapped. So it's any number of brain lesions, looking to see if we can provide that randomized evidence that radiosurgery can continue in some of these patients, provided better overall control. This trial, BN09, was looking at patients that we really worry about that have quite a few brain lesions progressing rapidly over time. Looking at whole brain radiation therapy as salvaging those patients so that they don't continue to fail with new brain lesions. And an area that we studied that doesn't have access historically to radiosurgery was small cell patients, that demonstrated that you actually can benefit them with radiosurgery for their cognition without sacrificing their survival. So we're also running, along with the rest of the NRG group, a randomized trial in that space as well. In the Hoosier network, the additional phase that we're trying to understand for patients with brain lesions is, can we just withdraw SRS in a randomized fashion altogether and use it as a consolidative means? And so using ALK inhibitors or osimertinib for lung cancer patients has an extremely high intracranial overall response rate. So we have a randomized trial ongoing right now with us, Stanford, Colorado, and a few sites in Michigan, looking at randomizing drug therapy alone versus radiosurgery and drug therapy. We're also including leptomeningeal patients. That was mostly based on data that we had from Ohio State that showed that there was no significant difference in these patients' overall survival or CNS PFS, and so we felt it was safe. How we manage patients at OSU, and hope that others do across the country, is that we take into account multiple of their baseline characteristics, because this is how we understand how patients will do. And we try to give them essentially a personalized approach. We've done over 100 patients now with targeted radiosurgery for even up to 98 brain lesions. And found that even with radiosurgery alone, these patients have a significantly good long-term outcome. And we can control these patients' brain tumors without the need for whole brain radiation therapy in quite a few. And so we think that this is a meaningful for these patients. Our overall control at Ohio State, we've published that the overall local control at a year is over 99% per lesion. In the grade 2 and 3 radiation necrosis, still less than 5%. Radiation necrosis or injury from our treatment is important because it impacts cognition. We know that location, age, and sort of the impact of this radiation necrosis on patients can impact their cognitive ability. We've looked at how can we improve that. We compared our linear accelerator based, or we have a version of radiosurgery called multi-met treatment versus Gamma Knife, which is another version or a tool that we use, and found that our version of the linear accelerator treatment has a significantly lower risk of radiation injury. That's also been shown in a randomized trial in Europe, unfortunately not significant because they didn't have enough patients, unfortunately, and the overall incidence of radiation injury was only 6%, but you can see that it was still lower even in the randomized clinical trial. What we use now is we started to transition surgery now after radiation treatment at Ohio State. We've been doing this for several years. We've published a number of accounts showing that preoperative radiation treatment can decrease radiation injury, decrease the rate at which we see leptomeningeal disease, and potentially improve control. And so we use what's called fractionated preoperative treatment. And then we also use a high rate of just fractionated treatments in general. We've treated several hundred patients over the last several years, and now have published sort of guidance for our radiation oncology colleagues on the safest version of treating this with multiple treatments. How do we manage radiation injury once it's caused? Typically, it's steroids. Bevacizumab, or a targeted agent to calm down radiation injuries, also used, as well as hyperbaric oxygen, used less often. We use an herbal remedy now, kind of standardly at Ohio State, which is a tree extract from India and the Middle East. There was a prospective randomized clinical trial done by one of our colleagues in Germany about 10 years ago that showed about a 75% decrease in edema in almost 2/3 of patients. So in a randomized placebo-controlled trial, they're able to show that an herbal remedy available over the counter can actually decrease brain swelling. We also use LIT and Trental vitamin E. This is just highlighting sort of our clinical use. We have about 150 patients on this clinical study now, but the clinical responses to this sort of tree extract, we had about a 55% overall response rate. And this is just highlighting that in the upper left, you can see that the necrosis on the far right got smaller by about half, and the edema, which is the white stuff around that area, got significantly smaller as well. So we do see some complete responses, which we don't typically see with steroids. And we do see a nice duration of response of almost a year. Surgical resection is also needed sometimes for these patients. And then how do we manage some of these sort of radiation injuries? We have an algorithm now. It's not all bad, though. The patients that get necrosis tend to live longer, typically because these patients respond better. And then we also have an ongoing clinical trial for patients, including melanoma patients, monitoring diet. It's called the Keto Brain Trial, where they either get the AICR diet or keto study. And those dietary studies are essentially looking at trying to decrease rates of radiation injury and improve control. So we're running this with one of our experts in the Ohio State system, with really just any patient getting radiosurgery. The neuropsychiatric study, this is also a clinical trial that we've just finished. It enrolled about 110 patients. It's a randomized study looking at specifically trying to improve cognitive ability. We randomized them to seeing a neuropsychiatrist to improve their overall quality of life and capacity. We also are utilizing a novel brain radiation treatment technique, because colleagues at Harvard have done brain mapping, so with injured patients. And you can see here that the brain mapping sort of localizes to these central structures that impact memory the most. These tend to be surrounding the fornix, the corpus callosum, the hippocampus. It's sort of these centralized thalamic structures tend to be the most important to memory. And so I kind of want to highlight here, you're essentially sparing, if you look at these, the orange here, and then the mapping here, we've come up with what we're referring to as memory avoidant whole brain radiation therapy, which is essentially an advanced version of whole brain radiation therapy that spares all of those important cognitive locations. And so we had about 50 patients on the trial using this memory avoidant whole brain treatment. We hope to bring this as a standard option that will likely improve cognitive ability to the current standard, which is just sparing one of these locations called the hippocampus. So we're sparing things like the fornix, the corpus callosum, the amygdala, the hypothalamus, and the pituitary. And then we also have this edema-X or EDEMX study looking at Boswellia to prevent symptomatic necrosis. Leptomeningeal disease, I'll just cover briefly. It is sort of a very difficult and critical disease entity that we face with melanoma patients, as well as breast and lung. We currently have been using what's called craniospinal, because a number of us around the US have been doing this for patients we felt were sort of long-term survivor potential. And we would give proton craniospinal to treat the entire neural axis. And we found in a randomized phase 2 trial that actually improves survival. So it improves the CNS PSFS as well as the overall survival for those patients. Again, this is for breast and lung, but there's also a cohort ongoing at Sloan Kettering and other locations studying both the combination of immune therapy with proton CSI and proton CSI for melanoma patients. Historically, melanoma patients, we just worried progressed quite quickly with, unlike the lung and breast patients with LMD. So they're a little bit more of a difficult cohort for patients to treat. But we do think that they can still benefit. So in conclusion, there's multiple ways for radiation oncologists to impact a patient's overall control and cognition. We are advancing our ability to treat patients with brain diseases and try to keep them functioning well for many years with controlled tumor. With that, I'll take any questions.